Great. So ever since you went away from Pakistan, we've done 16 more cases of poem up till now. Although because of COVID, we're not doing that many. Here, there's Saad. Hello, Saad. Assalamu alaikum.
Hi, Professor Saad. How are you?
Hi,
I'm
how are
Farid. Nice
you?
seeing you.
Nice seeing you too. Thank you for
Saad,
giving us
here's
your
Pareet.
valuable time.
He's
Of
my
course.
teacher on poem. He taught me
Oh,
poem.
Oh, he's the man.
Yeah, he's the man.
no, I have teaching you was like a no-brainer. I think anyone can.
Well, thank you very much. That was the beginning of the poem in Pakistan.
You've started. Yeah, you get the credit for starting poem in Pakistan.
Previously on workshops, Professor Fan had done a couple of cases, but he had done the cases. Nobody in Pakistan was transferred.
Yeah.
So
Nobody still is doing it. I mean, it's only Riaz, and that's through to you. I've asked him. I've requested him to enroll me as a student, but he's a busy man.
I'm not a busy man. You see, as soon as the COVID is over, but I shall be more than happy to have you here. I can come over to your center and do the procedures with you.
Whatever.
Yeah.
I know. I'm just joking.
Riazul Hassan is has already started to jump in, and he started to make in scene and do the clipping, and he has initiated the dissection. So
Sir, we are live.
Excellent. That's the way forward. Very good.
Okay.
Sir, we are live now.
Okay, perfect. Should we wait or should we start?
Sir, it's up to you.
And the people can join and we should start in time.
Okay.
And the audio is okay, right?
Yeah, audio is perfect. Perfect. Can you hear me perfectly?
Yes, I can hear you perfectly.
Okay.
Yes, you can start because we're live on Facebook as well. So.
Okay, perfect. Well, ladies and gentlemen, welcome back on the weekly webinar session on ES and ERCP. And this time, it's none other my own teacher on poem, Dr. Pareet. Next name is quite difficult, but I'm Mekaroon Kamul, and he's assistant professor of medicine in Division of Gastroenterology in King Chulalongkorn Memorial Hospital in Thailand. He's a great friend. He has been to Pakistan. He's spent for 1 week last year, and he left just before the COVID restrictions were about to set in. He has been trained in America, and he has extensive experience in the endoscopic surgical dissection, EUS, EMR, and similarly in ERCP. And he has been very kind to spare his time on a weekend. This is his Sunday, and on Sunday, the family day, he has been kind to spare his time for the Pakistan Society of Gastroenterology and gastroenterologists in Pakistan. Preet, all yours.
Well, thank you very much, Professor Saad, for the kind invitation. And let me tell you, I cannot wait to go back there to Pakistan again after this COVID era is over. And well, it's been my pleasure to come back on the webinar. And thank you all for joining, even though it's weekend. But let's hope for that. We can learn something today. And by all means, I would like this to be an interactive sessions if you can. We are live on Facebook, and we are also on Zoom platform as well. So the chat box is always open. If you have any questions, you don't want to stop me, please shoot your question in the chat. And as we go along, I'm going to have some questions, some cases where I would like you all to shout out your answers as well. So here we go. Today, my topic is going to be about the subepithelial tumors of the GI tract. And since there has been some paradigm shift over the past couple of years, we would like to go over that and any new updates on management of these lesions. So I have no disclosure. So today we're going to talk about what are subepithelial tumors and why are they important, how to diagnose them, and how to manage them. So let's start with the first case. This is a 60-year-old female underwent a screening colonoscopy. An incidental 2-centimeter submucosal lesion was found in the ascending colon. So this is what we found on endoscopic view. What do you see? And what would be the next best option? Whether A is going to be repeat colonoscopy in 10 years, B, CT scan of the abdomen, C, diagnostic EUS, EUS with FNB, or surgical referral. You can think of your answer as we go along, or shout your answer out in the chat box, okay? So this is something that we found common, okay? And first of all, I would like to point out on the misnomer of the endoscopic terminology. Submucosal lesion was the old term, and this suggests that the lesion is in submucosal plane, which is not necessarily true. Anything under epithelium, we don't know what plane they're in. They can be in mucosal, muscularis mucosae, they can be in muscularis propria, or can be in submucosal plane. So the correct terminology would be subepithelial lesion, okay? And as you can see here, there's a yellow hue pushing from underneath, going to the subepithelium. This is quite classic, okay? So before we know what to do, we have to kind of have the differential diagnosis in mind on what they can be. So these are benign subepithelial lesions that we commonly found in GI tract, lipoma, leiomyoma, varices, granular cells tumor, schwannoma, neuroma, duplication cyst, lymphangioma, inflammatory fibroid polyp, and pancreatic rest. And these are the ones with malignant potential or malignant tumor, including GIST, by far the most common one, neuroendocrine tumor, lymphoma, intramural metastases, and glomus tumor. The endoscopic findings of these lesions are quite diagnostic. Okay, even without the biopsy, you can tell with certain confidence that this is lipoma. You can do something called a pillow sign, which I'm sure you're all familiar with, using the forceps to poke on the lesion. The soft indentation pressured on the lesion suggests that what's underneath the epithelium is soft and it's non-mobile. When you see a positive pillow sign, this is actually over 95% specific for lipoma. And if it's equivocal, you can move on to do an EUS, which can be easily identified as hyperechoic area, usually in a third layer or submucosal layer. And they usually are asymptomatic, rarely cause any problems like hemorrhage or obstruction, and there's no treatment or surveillance required unless the patients are symptomatic. As you can see here on the US view, when you see a tumor as bright as this, as a homogeneous and hyperechoic, this is diagnostic of lipoma. There's no need for biopsy or FNB. Moving along on case number 2, a 60-year-old male underwent a screening colonoscopy. An incidental 1 centimeter subepithelial lesion with a central umbilication was found in the rectum. So what is the next best step? Should we just repeat colonoscopy in 10 years? Surveillance flexible sigmoidoscopy in 1 year, pelvic MRI, biopsy, or surgical referral? Okay, so this, before we know what to do, we kind of have to know what it is first. As you can see here, even though this is subepithelial tumor, but the overlying mucosa is not completely normal. There are dilated microvessels there. If you put on an NBI, you can see some dilated pit pattern, even though it's very organized, but it's not the same as surrounding mucosa. This is quite characteristic of a neuroendocrine tumor as well. The neuroendocrine neoplasm is a new term, NENS, a tumor originated from enterochromaffin cells. They are slow growing with malignant potential. All NENS can be malignant if you give it enough time. They can invade into deeper structures. Endoscopically, NENS appear small, round, sessile, and polypoid with some occasional central umbilication, depression, ulcerations. The characteristic of NENS as contrast to other subepithelial tumor is that Overlying mucosa is not always normal, and the overlying mucosa is usually very thin. So even regular endoscopic biopsy, not even bite on bite, can be diagnostic. So if you see something like this in the colon, removing it or biopsy it can give you diagnostic yield without any US. The rectal NENS is by far the ones with best prognosis compared to NENS in other area of GI tract. It's dramatic increase in incidence due to increasing screening colonoscopy. The prevalence is roughly about 0.05 to 7%. The treatment depends on size, and because size and depth impacts the lymph node involvement and overall survival. If the size is less than 1 centimeter, there's no surveillance required, just endoscopic treatment is enough. If it's 1 or 2 centimeter, usually EMR or ESD is enough. If it's larger than 2 centimeter, traditionally speaking, we would need surgical resection because it suggests more likelihood of lymphatic spread, but that's something that's up to debate nowadays, which we'll go on and talk about later on. And this is this is a band-assisted EMR because the lesion is small enough, is roughly about 1 centimeter. Using just a band with a cap can easily goes underneath the lesion, and we do a snare cut under the band, and we have an en bloc resection of the lesion. Moving on to the next case number 3, 50-year-old male underwent an EGD for bloating. An incidental 1 centimeter subepithelial lesions with central umbilication was found in the distal esophagus. Looks very much like the last case, but you can see here this is more white. The overlying mucosa is thicker. It looks like a molar tooth, and it's in the esophagus, not in the rectum. The bite-on-bite biopsy showed benign squamous cell epithelium. So what should be the next step? Surveillance EGD in a year, CT scan of the chest, diagnostic EUS, EUS FNB, or surgical referral. Have your answers in mind and see if they're correct here. So this one will go with just diagnostic EUS. So EUS guided sampling, you need to know when to do EUS and when to do the sample. Okay, the ESGE just recently published guidelines on EUS role in subepithelial lesions in 2018. So anything larger than 2 centimeter, then there should be hypoechoic. Any suspected GIST that is being considered for targeted therapy, or any atypical EUS findings, like for example, if you suspect NEN or lymphoma or intramural metastasis, all require some sampling. On the other hand, if the patient is already symptomatic and the tumor warrants a resection regardless of what it is, if it is small, meaning less than 2 centimeter in the esophagus or in the stomach, or it does have pathognomonic appearance of a lipoma or duplication cyst, especially in the esophagus, or if the patient is not candidate for treatment, these patients do not require sampling because it would not change our management. And worse off, the sampling can cause more problem, especially if you do some samplings in the duplication cyst or cystic lesions in the esophagus. It can cause infections of the cyst. And usually it's where the yield of FNB in this case of the small lesions are very, very low. So in this case, the subepithelial lesions is very small. And in the esophagus, it looks very benign. We can do surveillance for now. The problems with EUS FNB is that it can be low diagnostic yield. We reported 47 to 57%. And in Japanese guidelines and the largest retrospective trial, the sample may not be adequate for proliferative index. For example, if you suspect GIST, the Ki-67 index or mitotic index tend to be underestimated in these lesions. And there can be severe adverse events with FNB. 0.4% has been reported for severe bleeding. And there's also a theoretical risk of tumor seeding, but this has never been really proven in the literature that FNB of the subepithelial tumor can cause the malignant seeding. So when we do EUS, there are many types of EUS that can be used. First of all, there's linear echo endoscope, there's radial, there's a forward view echo endoscope, which can be used with a cap. These can be very, very helpful if you have a head-on lesions, like let's say in the duodenal bulb or a lesser curve or in cardia, where a linear EUS or can be difficult to maintain position. You can use cap to stabilize your scope and do a direct sampling. So the radial scope gives you more circumferential view of the EUS, but you cannot really do any sampling with the radial scope. But for linear echo endoscope and forward view echo endoscope, you can do sampling as well. For the small lesions, especially if it's less than 1 centimeter, a mini radial probe can be helpful. But whatever a probe you used, the higher frequency is better to see the superficial layer of the GI tract wall. Normally, the GI tract wall can be divided into 5 planes. The brightest hyperechoic plane in the with interface to the lumen fluid mucosal interface is hyperechoic, which is the mucosa. The black line underneath here is muscularis mucosae. The largest bright line, which is usually the thickest layer of the wall, is submucosa, and dark line, outer line is muscularis propria, and the most outer hyperechoic structure is serosa. If you use a high frequency probe like mini radio probe as opposed to 7.5 megahertz traditional linear echo endoscope probe, you can see up to 9 layers of the gastric wall. The additional 4 layers comes above the submucosal layer, meaning that you can see the muscularis mucosae clearer, and you can see the inner muscularis propria and outer muscularis propria with the connective tissue in between. This is particularly true in the esophagus and in antrum, where there's a separate plane of a circular muscle and longitudinal muscle. So if you have a subepithelial lesions in the esophagus that you need to clarify, that you think it's early cancer, that you want to clarify whether it's superficial or deep submucosal space invasion, the higher frequency probe allows you a more detailed evaluation of the wall. So in this case, an EUS was performed. A hypoechoic lesion was seen arising from the 3rd layer. As you can see here, the muscularis propria is intact and the tumor is above the muscularis propria. Dr. Kida has published a very well-organized review article here in digestive endoscopy, giving a differential diagnosis of 2nd, 3rd, and 4th layer of subepithelial lesions. If it's coming from the muscle layer, whether it's 2nd or 4th, we think about leiomyoma, GIST, glomus tumor, or schwannoma. The rest of it will be in the 3rd layer, mainly in submucosal layer. If we see an echoic lesion, that's almost always going to be cyst or lymphangioma. If it's hyperechoic, it's going to be a lipoma. If it's isoechoic, meaning same as liver, spleen, or hypoechoic, then the rest of it would be in this category, whether it's neuroendocrine, GIST, leiomyoma, schwannoma, glomus tumor. So if you have these diagram in mind, just using the originated layer and echo appearance of the lesion, you can have a rough differential diagnosis in mind of what you can expect. So granular cell tumor is a rare neural origin tumor commonly found in esophagus and proximal tumor. It's usually small, is polypoid-like, white color. The overlying mucosa is usually thick, and it resembles the molar teeth appearance, which is something that we found on this case. It's usually hypoechoic, homogeneous, with smooth margin, usually arise from the 2nd or 3rd layer. It's generally benign, but a very, very rare malignant transformation has been reported. It is almost indistinguishable to inflammatory fibroid polyps, but inflammatory fibroid polyps usually found in the stomach as opposed to the esophagus. But you can see here the EUS finding is very much the same. It is fibroid polyp is benign, is somewhat rare too, is usually semi-pedunculated, is protruding with a white cap on top. There can be a central umbilications, is usually hypoechoic and homogeneous. It can involve the muscularis propria and can be misdiagnosed as GIST. So moving on to the next case, a 40-year-old female underwent an EGD for dyspepsia. An incidental 1 centimeter subepithelial lesion was found in the antrum. And just by endoscopic findings here can be diagnostic already, right? You can see the normal overlying mucosa with a characteristic central umbilication in the antrum next to the just proximal to the pylorus on the posterior wall of the antrum. If you're not sure, you can do an EUS, but EUS would give this pathognomonic sign. Right here, you can see a salt and pepper-like echo findings of the tumor arising within the submucosal layer. You can see a central anechoic structure right here, or you can see a tubular structure with hyperechoic wall. So this is a pathognomonic sign of pancreatic rest. You can see it's looks very much alike a pancreatic tissue with a pancreatic duct-like structure in the center of the mass. So with this finding, you don't have to do anything else. You can certainly diagnostic of pancreatic rest, and no surveillance or treatment is needed. Pancreatic rest is an ectopic pancreatic tissue, usually located in the gastric antrum, in the greater curve, in the posterior wall, greater curve. Commonly arise from the third layer, but it can involve any layers of the gastric wall. It can be mixed echogenic with internal structure suggesting pancreatic duct. Moving on to case number 5, a 35-year-old male underwent an EGD for worsening abdominal pain. This patient is actually a friend of mine who has chronic dyspepsia for a while, but his dyspepsia got worse. He called me one day, his pain is really, really severe. He had to go to the ER. All the workup has been negative. He had an EGD done prior, which did not find anything. He has a few episodes of severe pain like this that warrants him to go to ER. So we decided to do another EGD, and the EGD did find this finding. I'm sorry, there's no endoscopic pictures, but the endoscopic picture looks very much like this, like our last case. It looks, and then we proceed to do an EUS, and EUS found something like this. So it's a mixed hypoechoic lesion with a central cystic degeneration, if you will. There's an anechoic structure in the middle surrounded by hyperechoic rim. And the lesions can be seen originating from the muscularis propria of the gastric wall. You can see here. So what is this? And what should we do about it? So because we cannot differentiate these lesions from a GIST with cystic degeneration, which is the high-risk feature of GIST, we did an FNB. So what most likely would be the diagnosis in this case, right? As you can tell that, the two main differential diagnoses that we had in mind here is either neuroendocrine tumor, because it's mixed anechoic cystic solid tumor. It can be a GIST with cystic degeneration. It can be a pancreatic rest, because it has a very much endoscopic appearance similar to pancreatic rest in our last case. So the FNB was not so helpful. The FNB was non-diagnostic. We decided that because the tumor of unknown nature is still there and the patient is symptomatic, we decided to do an endoscopic resection. And because of the location of the tumor in the antrum, we proceeded with submucosal tunneling endoscopic resection, which is similar to what we do for G-POEM for gastroparesis or POEM for achalasia. We do a tunneling along the gastric wall, along the antrum, find tumor and remove the tumor out of the tunnel, and we close the mucosotomy area. And this is what we did. We did a little blip on the antrum. We go into the submucosal plane of the antrum. We do continue with the submucosal dissection along the posterior wall greater curve of the antrum until we found this tumor. A 2 centimeter non-encapsulated white elongated tissue was found. As soon as I found this, I know that this is not a GIST, right? A typical GIST is well encapsulated. It's originated from the muscularis propria, as we saw on the EUS. But this is non-encapsulated tissue, and it gives rise all the way to the mucosa. This is the mucosa up top right here. Hence the central umbilication portion of the endoscopic findings. So after resection, as you might have guessed, the pathology reported show a calcified pancreatic tissue. So going back to the EUS findings, as you can see here, it explains why there's some cystic degeneration right here and some calcification along, because the patient has pancreatic rest that was complicated by acute pancreatitis. But because the patient was symptomatic, that's why the tumor needs to be resected. Moving on to the next case number 6, a 70-year-old male underwent an EGD for postprandial nausea. 2.5 subepithelial lesions was found in the second portion of duodenum. As you can see here, the tumor was nearly obstructing the lumen. If you found a subepithelial lesions like this with normal in the overlying mucosa, please be careful, because in the second portion of duodenum, this can very well be ampular tumor. So it's better be evaluated with both side view duodenoscope and in EUS scope. And Lord behold, when we use a side view duodenoscope, we did find an orifice, a biliary orifice of this tissue, of this mass. So this is indeed an ampullary subepithelial tumor. So what should we do next? Should we do a biopsy? Should we do a CT scan? Should we just do a surveillance endoscopy, EUS, or surgical referral? So in this case, because there's obvious endoscopic finding of subepithelial lesions, we proceed with an EUS. And I just gave you the answer. The EUS found a hypoechoic lesion adjacent to the bile duct and pancreatic duct, and the lesion arise from the muscularis propria. As you can see here in the yellow arrow showing the muscularis propria layer of the duodenum, and the lesions arise from the MP. So we did a FNB of the mass, and the FNB show these pathologic findings of a multiple small round cells tumor. And that's correct. The pathology reported shows small round cells. The subsequent immunohistochemistry stain confirmed neuroendocrine neoplasm. So duodenal NENS, as opposed to our first case, carries worse prognosis. Similar to gastric NENS, this is a little bit more complicated than rectal NENS. NENS in each area of the GI tract is different disease. The gastric NEN and duodenal NENs have different ways for us to approach them, different ways of diagnosis, and different ways of treatment, something that we don't have time to cover today. So just focusing on the duodenal NENs, we separate from how we manage them by just see if they're ampulla involved or not, and the size of it. If they involve the ampulla, the primary treatment would be surgery and lymphadenectomy, because the higher chance of lymphatic spread. If it's non-ampulla, then we go by the size. If it's very, very small, less than 1 centimeter, you can do an EMR. You can do an, if it's 1 to 2 centimeter, you can do an ESD. If it's more than 2 centimeter, the conventional treatment would be surgery with lymphadenectomy as well. But that's something that we can up for debate too, because this is a very, very rare tumor. So the available literature is not nearly enough for us to draw guidelines from them. And traditional speaking, all of the ampular NENs that presented, usually patients are usually asymptomatic, and the progression of the disease usually advanced. In this patient, however, declined surgery due to his age and underwent endoscopic ampulectomy instead. We do a biliary and pancreatic cannulation first, and we do an ampulectomy, and this is the base of the lesion. So you can see here is the muscularis propria with the submucosal plane on top. So we know we had an en bloc resection of the mass. A pathology report showed grade 1 NEN with negative margin. The follow-up at 2 years so far has shown no recurrence. So moving on to the next case, a 40-year-old male undergoes an EEGD for intermittent dysphagia, found to have a 1.5 centimeter subepithelial lesions at distal esophagus. So what should we do? A biopsy, a CT scan, a repeat EGD, an EUS, or surgical referral? As you must have guessed by now, with the theme of our topic today, yes, it has to be an EUS, right? So an EUS was performed. The mass was homogeneous, hypoechoic, arisen from a muscularis propria. As you can see here in a white, black line, and the lesions is surrounded by the white line of the submucosa on top, but the base of the lesion is attached to the muscularis propria right here. So going back to our differential diagnosis, anything coming from the fourth layer, you think of a few differential diagnoses: a glomus tumor, a GIST, a leiomyoma, or a schwannoma. And each one of them carries different prognosis. So leiomyoma and schwannoma neuroma are quite benign, while GIST and glomus tumor have malignant potentials. All GIST is malignant if you give them enough time. So there's no such thing as benign GIST. There's only low-grade or high-grade GIST for now. The GIST is by far the most common mesenchymal neoplasm of GI tract. It's commonly found in the stomach, but other areas like small intestine, esophagus, and colon can be found as well. Small intestine GIST is by far the worst prognosis. Hypoechoic and homogeneous on EUS. Even anything larger than 3 centimeter with irregular margins with cystic degeneration suggests of aggressive phenotype and should be resected as such. Cytology can give us some proliferative index that can give us some clue on the aggressiveness of the tumor. You typically show spindle cells with positive CD117 and positive DOC1. There's no DOC1 with no GIST. So all GIST has to have positive DOC1 immunohistochemistry stain. The Ki67 and metatic rate tends to be underestimated from FNB specimen. As compared to leiomyoma, which is non-differentiable from GIST on EUS, it also shows a benign smooth muscle tumor, hypoechoic homogeneous, typically arise from muscularis mucosae or muscularis propria, but the location is typically in the esophagus, more on distal esophagus and mid than proximal esophagus. When you have some tissue, it will be negative for CD117 and CD34, but positive for desmin and smooth muscle actin. A glomus tumor is a mesenchymal tumors commonly found in the skin. Glomus tumors have, like GIST, malignant potential. It's usually well circumscribed, hypoechoic, with internal heterogeneous echo mixed with hyperechogenic spots. So this is something that you can somewhat differentiate it from EUS, but it's non-specific or non-pathognomonic. So if you see something like this on EUS, typically you would still need a tissue to make a diagnosis of what exactly it is. So seeing these on the US begs the question of, what should we do? Should we just do an F&B? Should we do a surveillance, or should we resect it? So the role of a resection for subepithelial tumor is now up for debate, especially with new modalities for endoscopic resection. And now we have more understanding of its natural course of disease. A very few of them grows over time. The largest study to date from Japan and China with more than 2,000 patients show that less than 4% of patients of subepithelial tumor, regardless of histology, only grows over the course of 5 years. So as you can imagine, doing surveillance for all of these patients or doing resections for all of these patients can be very burden for both financially and clinically for the patient. So the role for tissue acquisition and early resections are still unclear. The malignant risk is low, but not absent, certainly. The resection is almost always indicated when the tumor is large, typically more than 5 centimeters. Some guidelines say, if it's bigger than 2 centimeters, it needs to be resected already. If the patient is symptomatic, and that's no brainer there. Or if the patient is unwilling to continue surveillance. As you know, EUS is costly. It can be expensive to do a surveillance EUS every year. And size does not always correlate with symptoms. The tumor can be very big, but it can grow outward and does not cause any symptoms. That does not mean that the tumor does not need resection. The modality of resection of surgery versus endoscopy. Surgery is still mainstay of treatment in most of these cases, but some selected cases can be resected endoscopically with new modalities if it is available in your center. Emerging endoscopic techniques for resection, such as exposed versus non-exposed, EFTR, stands for endoscopic full thickness resection. New techniques such as STIR, submucosal tunneling endoscopic resection, mucosectomy, enucleation, or device-assisted bands or clip, which we're going to go over a little bit and later on. And that depends on the depth of the tumor, determines the depth of resection. It can be the same mass, it can be the same size, it can be the same histology, but the direction of growth determines on what to do with it as well. If it's endophytic, meaning in the type A, if it's intramural, and type B, or exophytic in type C. Obviously, if it's type A, it's going to be the easiest to resect it. And there's also a dumbbell or mixed type where the tumor can be in both endophytic and exophytic. These are somewhat difficult lesions because you can be misguided that it's going to be easily endoscopically resected, but once you dig in, you can see that the tumor root is growing outward and outward into the peritoneum. So endophytic intraluminal subepithelial lesions, anything above muscularis propria with well-encapsulated tumor, it can be resected with endoscopic submucosal dissection regardless of size. Granted that you have to make sure that there's no lymphadenopathy, there's no signs of distant metastasis, and the feeding vessels underneath the tumor is manageable endoscopically. For example, this is someone with 2.5 subepithelial lesions arising from the second layer, the muscularis mucosae. The tumor is well encapsulated, is in the gastric antrum greater curve. It was easily resectable using an ESD with less than an hour procedure time. The base of the tumor looks clean, dry, and intact, and is en bloc removal of well encapsulated GIST. However, if the tumor is in the esophagus, like our case here, if it's small enough, we can do a STIR technique. And ESD or STIR has been recognized by multiple literatures that it allows an en bloc resection with higher than 90% success rate with less than 5% adverse events rate. And this is what we did for our patient right here. We found a tumor arising from the GEJ and the distal esophagus. We do a submucosal lift, similar to what we do with POEM for achalasia. We enter the submucosal plane. Once we enter the submucosal plane, we continue with submucosal dissection. Care has to be taken to see where the tumor is. And typically, I open the mucosotomy just a few centimeters above the tumor, because otherwise it's going to be very difficult to find a small tumor in the submucosal plane. So once we found the tumor, we slowly dissect the overlying submucosal fiber, and until the root, if you will, or the base of the tumor can be seen attached from the muscularis propria, and we leave that for the last area to resect, because we know there's going to be a full thickness resection. So as you can see here, the overlying submucosal plane has been dissected and separated. We found a muscle fiber attached to the tumor to the wall of the esophagus. Then we started dissecting the base of the tumor. And once the base is dissected, the tumor was removed, and it's en bloc removal. So moving on to the next case, 46 years old, female, underwent an EGD prior to gastric bypass surgery. A 1.5 centimeter mass on lesser curve just below the GE junction was found. This is typically a troublesome area for the surgeon, okay, because it's right attached to the GEJ. Even though the tumor is very small, it can be a very morbid surgery. Patients can have a refractory GERD afterward. And as we all know, these tumors tends to be very slow growing or very benign course. So we're often faced with the dilemma of what to do. Do we surveillance, or do we resect it? Sometimes the patient was sent for a transplant evaluations, and the surgeon needs to know that this is not malignant. So we ended up having to do a whole workup. The EUS was performed and showed 1.6 centimeter by 2 centimeter hypoechoic homogeneous oval-shaped neoplasm. You can see the very well encapsulated area, and is attached to muscularis propria on the fourth layer right here. Its sharp demarcation suggests very benign features. EUS aspirate was non-diagnostic, non-surprisingly, because it's very small. So the ways to remove this type of tumor, you can do a stir technique like what I showed before, or you can do something called an ESML, meaning endoscopic submucosal resection with ligation device, or a hybrid resection for a large tumor. So the band ligation assisted EFTR, similar to enucleations technique, we cut the overlying mucosa of the tumor, exposing the encapsulated tumor underneath, and use a cap-assisted device to suction the tumor into the cap, meaning that the tumor has to be less than 1.5 to 1.8 centimeter to be able to be suctioned completely. And then we use a band and then use a snare to cut under the band and close the mucosa. And this is how it's done. We typically inject overlying mucosa and do the mucosectomy. It has to be done very carefully, not to break the tumor capsule. And once we found the tumor capsule right here, we expose more of the submucosal plane, and we use the cap to engulf the tumor, suction it until we see the base of the tumor. And then we put band underneath the tumor and cut under the band. And you can see that the overlying mucosa is still intact, and we remove the tumor en bloc. As opposed to someone like this, a 68-year-old female with abdominal pain, EGD revealed a 5 centimeter endophytic mass near the cardia. The tumor is obviously large, with God forbid, a very large vessels underneath in this semi-pedunculated area. Like I said, it's a very troublesome area for the surgeon, because we want to save the GE junction and do a less morbid surgery. So in this case, we do a push-pull method, meaning a hybrid method between the endoscopist and the surgeon. As you can see here, the surgeon helped us do a laparoscopy, found the stomach, and from outside the laparoscopy, the surgeon can push the tumor inside the gastric lumen. And once the base of the tumor is pushed inside the gastric lumen, that's easy for us. We use the largest snare available, which is like a 3.5 centimeter snare. Just go over the base of the tumor. And we want to do a full thickness cut. And because the surgeon is right outside the peritoneum, there's no concern whether it's going to cause a large hole. So we do make sure we have an en bloc resection of the mass right there. We typically pull and strangulated the mass for a few minutes because any feeding vessels can be strangulated. And you can see that we cut some part of the omentum along with the mass. So there's a little hole and we use a forceps to push that hole outside into the peritoneum so that the surgeon knows what to look for. And it's going to be very easy for them outside to see the light from our endoscope and just do closure from outside. So the whole procedure took less than an hour to remove. Next case, a 55 years old male undergoes a screening colonoscopy. A 1.5 centimeter subepithelial lesions was found in the rectum. The patient is completely asymptomatic. You can see here it's roughly about 3 to 4 centimeter above the dentate line. The EUS show that the mass is from muscularis propria next to the prostate and the bladder right here. So the FNB was done and it's confirmed a rectal GIST. Because it's GIST, it needs to be removed. Traditionally, this would require a surgical resection, but because it's in the rectum, it's on the anterior wall, which is typically a little bit easier to remove. So the endoscopic full thickness, endoscopic full thickness resection was performed. And it goes very, very deep, as you can imagine from the EUS findings right here, that is quite exophytic outside of the lumen to the prostate and the bladder. But because it's very well encapsulated, the full thickness resection could be done. Typically in the rectum, it's vascularized, vascular rich area. So there's a lot of small vessels that needs to be coagulated. But because the tumor was well capsulated, it can be removed en bloc as well. The pathology confirmed a low-grade rectal GIST with negative margin. Recently, ASGE recognized that the development of new modalities to remove subepithelial lesions, including the EFT, EFTR, and STIR. It has published recent guidelines showing that these endoscopic modalities can be an alternative to surgery in someone who's not a surgical candidate, who's not willing to undergo surgery, and they don't have any signs of metastasis or local lymphadenopathy invasion. So complete resection rate of up to 52 in early phase and up to 97%. Most studies come from China, where the overall high success rate has been reported. But that does not come cheap. It comes with 12% of major adverse events that eventually require surgery. And these usually seen in large tumor, typically more than 5 centimeter. But if the tumor is median size of 2 to 3 centimeters, it usually can be managed endoscopically. Last case of a 45-year-old male who presented with melanoma and underwent an EGD that shows subepithelial lesion in distal duodenum. So when you see something like this with the purple color subepithelial tumor, if you will, please do not biopsy, please do not FNB, and when you do an EUS, definitely put the Doppler on. So this is a large ectopic varus in the duodenum, and ectopic varus can be seen in patients with portal hypertension. It can be seen in duodenum, in rectum, in parastomal area. If you don't have glue available in your center, such as in North America, you can do a banding with lower success rate as opposed to esophageal varices. And TIPS is the first line treatment. If you look at the guidelines from the North American side, BRTO, surgical shunt, and glue injection are alternatives. So in summary, when you see subepithelial tumor, you see a few things. If the tumor size larger than 2 centimeter, if the patient is symptomatic or not, if you have any concerning EUS features such as cystic degeneration, a mixed hyperechoic, a mixed cystic solid signs on the US, irregular border, or large feeding vessels. Those are concerning features on the US. If you don't have any signs of concerning features, a very small asymptomatic patients, you can do a periodic surveillance. But if you do have any signs of these red flags, you need to do some GET tissue acquisition, whether it's going to be a bite-on-bite biopsy. If periodic surveillance show that the tumor increases in size over time, over the course of years, or if there's any echogenic change, or if the patient becomes symptomatic, you also requires tissue acquisition. If bite-on-bite biopsy is non-diagnostic, you move on to EUS. If EUS show any signs of deep invasions to MP, beyond MP, beyond serosa, any signs of local lymphadenopathy, then that patient needs to go to surgery. If it's benign appearing lesions, anything superficial above the third layer, meaning the submucosal layer, you can do an EMR or ESD. If the lesions is benign appearing and involves the fourth layer, meaning that it has to be a full thickness resection, you do a stir or EFTR technique or surgery depending on institutional availability. In conclusion, subepithelial lesions of GI tract have wide range of diagnostic and prognosis. Endoscopic appearance is not reliably diagnostic, and EUS is typically required. Tissue acquisition might be indicated in large tumor or symptomatic patients where the diagnosis or histopathology would change management. And last, size, location, histopathology, and symptoms determine modality of removal. And with that, I would like to thank you for your attention and welcome any questions. Thank you very much.
Thank you, Preet. That was an excellent session. You spoke very well on a difficult subject. I understand that there are not many people who can speak so competently on this very subject. You've made the things so simple and so easy for the audience. Can I ask you one question? What is the tool of your choice to evaluate the subepithelial tumors? Do you prefer using radial or you prefer using linear?
If it depends on size as well and location. If it's very small, I actually prefer a mini probe, a mini radial probe, where you can have a high frequency evaluation. Anything above 20 megahertz gives you a very nice overview of the layer of the GI tract. The problem with mini radial probe is that you need it to be submerged underwater. So if it's in the stomach area, patients probably needs to be intubated so that you can fill the stomach with water. But if it's something like duodenal bulb, a small area, a mini radial probe would be something beneficial to start on. A radial probe is good for anything less than 2 centimeter. In my experience, even anything larger than 1, where I think that I might need to do an FNB, like let's say if I go in and I see some concerning features, whether it's non-encapsulated tumor or irregular borders or a mixed hyperechoic features, I want to be able to do an FNB. So I like start with mini radial and move on to a linear probe.
Okay, what frequency do you use if you're using radial? Are you using 5, 7.5?
I go with the
10,
highest available on the machine, and that's typically 10, 7.5 to 10.
So, okay, right. So you always prefer with the radial and you go for the higher frequency.
Yes. Mm-hmm.
Any other question? Well, there's been a question by Dr. Tran. What was the reason to resect the small SMT right above each junction? It looks like a small leiomyoma. Can you please guide?
Come again, please. Mm-hmm.
What was the reason to resect the small subepithelial tumor just above the each junction, as it looked like a small leiomyoma?
So the patient was evaluated for kidney transplant, and they needed some tissue diagnosis to make sure that there's no malignant cells. And even though this, we think this is most likely benign, but the FNB was non-diagnostic, and because it was needed for her transplant candidacy, that's why we decided to do a removal.
Mhm. At one point, you suggested that putting a cap on the endoscope and doing the evaluation. We've not been able to follow the thing exactly. In which scope do you use the cap, and what are the exact situations where you're going to use the cap?
Good question. So the cap is only designed for a forward view scope. Okay, a forward view EUS scope, which is available mainly in Korea and in Japan. It's not available in Thailand as well, so I have quite a limited experience on it. But the idea is that, well, let me share my screen right here so that I can show you the picture again.
You the oblique view, yeah.
So am I still sharing my screen?
No, we can see you, but not your screen.
Let's see. Okay. Okay, can you see my screen now?
No, not really.
Not really. Oh. Now.
Yeah, no, we can see it. We can see.
Okay. So right here,
Right here.
this is the forward view EUS scope. So the benefit of this is that it moves very much like a typical in-view gastroscope. So it's very easy to maneuver. You don't really need to have a specialized training with it. So non-advanced gastroenterologists can maneuver this into the lesion, and see the lesions head on and do a simple biopsy. It's helpful for the very small lesions where and in the difficult angled area, like at the posterior wall of duodenal bulb, or in cardia, or in the very difficult tortuous colon, right? Because you cannot really maneuver the linear scope in the colon really well. But if this is a forward view EUS, you can maneuver this inside the colon and find the lesion. Using a cap over this would allow you to be able to field the probe underwater and give you a better echogenicity. Hope that answered your question. But if you don't have this type of scope available, the other thing you can do with this radial and linear probe is to do a balloon on top of the probe and submerge the balloon with water, and gives you a better view on EUS, similar to using a cap as well.
Mm-hmm. Dr. Then how many centers in Thailand you have the mini probes available for use?
I don't have the exact number, but my guess would be less than 5. We usually have mini probe for like intraductal EUS for bile duct, or some centers where we see a lot of subepithelial lesions. Fortunately, we have quite a good support from the scope manufacturer. So in Thailand, I know for a fact that there are 3 mini radio probes where it does not belong to any institution. It can be borrowed from institution to institution. So like, let's say if you have a case, you can borrow them and use it on for a day or 2 or something like that. And generally we get support, good support from the manufacturer.
That's a good arrangement. That's a good thing to do. There's a question from Apus that do you make further classification for GIST as GANT, GNT?
Come again, please.
Do you make further classification for GIST as GANT, GANT?
Yes, for the GIST tumor, we typically classify, based on, the low grade, mitotic grade, and size, meaning that, if it's like less than 5 centimeter, more than 5 mitotic grade per high power field, or Ki67 more than 1. So if you meet any of those criteria, I tells my fellow like 10, 10, and 5, 5, more than 10 centimeter, more than 10 mitotic grade, or 5 plus 5, meaning 5 centimeter and 5 mitotic grade. That goes to high risk GIST, and it needs to be surgically resected with a high risk of metastasis. If it's and it typically needs also adjuvant gleevec, meaning that to reduce the size of the GIST first and reduce the risk of relapse. If the GIST is less than 5 centimeter, less than 5 mitotic grade, endoscopic resection with en bloc negative margin is usually enough. That does not require chemotherapy. And I think that's one of the key features for us to be able to get a accurate proliferative index prior to resection as well, to determine whether the patient would need neoadjuvant chemotherapy before, and that should be done in a multidisciplinary team. Certain area of GIST does not requires more than just classification. For example, if it's in the ampulla, if it's in the GE junction area, or if it's along the dentate line area, these areas are highly morbid surgical area. So we would need a neoadjuvant chemotherapy to reduce the size of the lesions before removal, to reduce the risk of morbidity, regardless of the classification of the histology.
Right. Pradeep, any particular trick that you want to share to decide about the modality of treatment based on the layer and type of the lesion, subepithelial lesion?
Yes. I think that the endoscopic modalities nowadays has rapidly evolved beyond the guidelines can catch up. One thing that our area for improvement certainly is superficial lesions, where the tumor arises above the MP layer, meaning from the second layer or superficial third layer. These can generally be resected with ESD, regardless of size. Granted that larger the tumor, the higher risk of lymphatic spread and higher risk of metastasis. So before you embark on endoscopic removal, it is imperative to properly determine surgical candidacy, determine the risk of metastasis, whether it's going to be an EUS to see the lymph node or cross-sectional imaging to see distant metastasis, and determine that the patients would be compliant for post-resection surveillance. Because even though you have an en bloc resection of the tumor, we do not have enough long-term data for these type of resection, because they are so novel, to know what would be the likelihood of recurrence. So the patient is imperative for the patients to know that he or she would still require long-term surveillance. For a larger, deeper lesion, I would discuss this with your gastroenterology team and surgeon and oncologist as well. The decision to remove this surgically, like let's say, for example, if it can be done like simple wedge resection on the greater curve of the stomach, half an hour surgery, then sure, then surgery should be the one to go. But if the tumor is in the morbid area that the patients would require, like let's say colostomy or cause a big surgery like Whipple surgery, then endoscopic resection can be attempted, knowing that there's going to be a significant risk of incomplete resection or local recurrence. But endoscopic modalities is still a good alternative in a very selected patients.
Paritha, what is your experience with the right side colonic endoscopic ultrasound? Do you do it regularly? And how do you do it?
No, and I think that for the right side endoscopic ultrasound, you typically required either a forward view EUS or a long mini radial probe. It is easiest to be done with mini radial probe because the mini radial probe can be just through the channel with regular colonoscope. Like let's say if you go into the cecum and you found appendiceal subepithelial tumor that you suspect that, oh, this might be a neuroendocrine tumor, that you want to make sure that this is not just a simple lipoma before you send the patients for a right hemicolectomy. You can just use a mini probe through the channel, go have the probe on top of the lesion, and see quickly within a few seconds whether this is lipoma or is it a hypoechoic tumor. If it's a hypoechoic tumor in the colon, almost always it needs to be resected regardless of what it is. It is very rare for leiomyoma to be in the colon. It can still happen. So that should be in your consent form with the patient as well. If you don't have any of those, if you don't have the forward view EUS or mini radial probe, you can still have a radial or even a linear EUS over guide wire to the right side colon. But that also requires a great maneuverability of the scope and someone who's really experienced in handling this type of scope because it can be very high risk and very difficult.
Great. But pretty number of times, I know we've overshot the time. It's already 5 minutes up, 5 past 7. Number of times in the upper endoscopy in the duodenum, we find a small submucosal subepithelial lesion and we just pluck it out with the biopsy forceps.
Mm-hmm.
And the report comes as neuroendocrine tumor. Do we need to follow that? And in case we follow that, how frequent do we need to do the follow-up, and what are the usual outcomes?
If it's in the rectum, if it's less than 7 millimeter, meaning smaller than the jaw of the forceps, I tell the patients that it's cured, it's been removed. The chance of this killing you is very, very small. But if it's in the stomach or in duodenum, that's another story. If it's in the stomach, you need to clarify first whether that's type 1, 2, or 3. Right? If it's let's say type 1 with atrophic gastritis, the prognosis is really good. You typically go back in and make sure that you have removed it all, not just the biopsy. If you haven't removed it completely, then you do an EMR. If it's type 2, then you need to find the culprit gastrinoma, where the tumor is and resect that rather than just treating the neuroendocrine tumor. But if it's type 3, meaning that the gastric pH is normal, gastrin level is normal, you think it's sporadic NEN, these carries a worse prognosis. So I tend to go back in right away. As soon as I got the pathology result back, I call the patients back and making sure that I removed it completely. Because if you wait too long, you won't be able to know where was it exactly, especially if it's small. You want to go in where you can still see the scar, and hopefully you don't have the submucosal fibrosis yet, because you want to remove it en bloc with an EMR. If you have it en bloc with EMR and you have a negative margin of pathology, you're in luck. Then you don't really need to do a surveillance afterward because you have removed it completely already. But if you have a positive margin, or if you haven't removed it en bloc, then you kind of get us stuck in a rock and a hard place because there's no guidelines available to tell you what to do. I typically follow them every 6 months to 1 year in the first 2 years, and space it out afterward. But this is highly anecdotal, if you will. If it's duodenal duodenal NENs, you need to know whether it's ampulla, it involves the ampulla or not. If it involves the ampulla, then I would typically go for surgery if you have positive margin. But if you have a negative margin, you can do the same thing with surveillance scope and do a frequent once in the first 2 years, and you can space it out afterward.
Perfect. Nadeem, do you want to say something? Nadeem, are you there?
I am, sir. Thank you very much, Preet. I think it's a fascinating talk, and we all enjoyed it. I'm just going to sort of re-emphasize some of the points that you've already made. And one of those is, especially for the trainees listening, it's really important that you do a good white light or enhanced image examination of the mucosa that you are looking at, because most of the time you're looking but you're not seeing, and that is again because you haven't paid adequate attention to an area of abnormality. I mean, our approach is slightly different when we're looking at the upper GI compared to the lower GI mucosal lesions. Say, for example, if you come across a flat area of abnormality in the colon, then we prefer not to take biopsies, because if then you have to refer these patients for the EMR, then it may become slightly challenging, whereas this rule may not apply to an upper GI lesion, especially in the esophagus. So I think those things are really, really important to take into consideration. I think the learning for me from this talk, which was, I think, very important for all of us, is to ensure that these neuroendocrine tumors, you have to pay particular attention to the site of the pathology, because as Preet have very nicely demonstrated, that the treatment and the surveillance pathways are really different. Also, one quick trick, I think what we have done is just print out those CD's classification from 2017 and make sure they're available in your department, so that you can have a quick reference guide. But it's really important to pay attention to these small incidentalomas sometime, which may not be of any consideration, but in cases like the one described earlier, where a pancreatitis developed in a pancreatic rest. So paying attention helps, and I'm very grateful for a fascinating talk. Thank you.
Preet, may I suggest you something that we can change the topic of this talk, subepithelial tumors of gastrointestinal tract, made easy by Preet.
Oh, thank you. You're too kind, Professor Guys. It's always a pleasure.
Thank you very much. It was a lovely to have you here. It was a wonderful session. We all enjoyed it. We all learned from this session. And I wish you a very safe period from COVID, and wish you a very happy life. We'll love to have you here, and we'll love to learn more from you, especially the endoscopic surgical dissection techniques and STER, and similarly full thickness resection techniques. Thank you very much on behalf of Pakistan Society of Gastroenterology and College of Physician Surgeons and all the other academia. And we are really grateful. Take care. Allah Hafiz, and see you next week with new topic.
Thank you. Bye. Stay
Bye-bye.
safe. Bye-bye.